first speaker, Dr. Hong-woo, Nanuri Gangnam Hospital. Please start.
Greetings, I'm Dr. Hong-woo from Untitled General Hospital, Singapore. This project is in collaboration with Dr. Hyo-sung Kim from Nanuri Hospital, South Korea, on a comparatively clinical and radiological cohort study of unilateral thoracic endoscopic laminotomy with bilateral decompression using one block resection technique and thoracic open laminotomy with bilateral decompression for thoracic OLF. We have no conflict of interest. Thoracic OLF is an uncommon cause of thoracic myelopathy. Open surgery is generally recommended with symptomatic thoracic myelopathy. Endoscopic spine surgery has improved instruments optics and provides solution for lumbar and thoracic region. There's paucity of literature in comparative interventional cohort study between open versus endoscopic. We have done a evaluation in terms of clinical results and radiological imaging of MRI for these two groups. This material methods wise, we did a retrospective comparative interventional cohort study with patients who are included with JOA score of less than or equal to 10. We did preoperative CT, MRI, and clinical evaluation in terms of VAS, ODI, JOA score, and MAGNAP score in the interval of 1 week, 6 months, and final follow-up. We've included 35 levels of endoscopic and 24 levels of open surgery. In terms of results, we find that there's no difference in terms of age and sex. There's a shorter follow-up in the endoscopic group, and they have less complication in the endoscopic group as well. There's a VAS, and in terms of VAS, ODI, and JOA score, clinically, there's statistically significant improvement in both groups of patients. And comparing the two group techniques, endoscopy does better in terms of JOA score and final VAS statistically significant. These are pictures showing the radiological results and a surgical video showing our technique. In the 3 o'clock position, there's T10 chordolaminar, and in the 9 o'clock position is our cephalic lamina of T9. In the 6 o'clock position is ipsilateral side. We did start our drilling, endoscopic drilling at the laminofascic junction at the ipsilateral side. We move towards the cephalic lamina, carefully doing the laminotomy. And we do the over-the-top decompression of contralateral cephalic lamina. Subsequently, we also do endoscopic drilling of the chordolaminar, ipsilateral and contralateral side, all in the attempt to thin out as well as delineate the lateral aspect of the ossified ligamentum flavum. When it is sufficiently thin, you can see a thin layer of the epidural space, and we can lift up the entire single block of OLF in one piece. In this case, we did some final trimming with a Garrison ronger. These are the intraoperative pictures showing good decompression of the thoracic dura. And on a good specimen, we can take the entire block of OLF. In our conclusion, we find that in experienced hand, endoscopic decompression can be considered as an option for surgical treatment for symptomatic OLF, despite the steep learning curve of endoscopic spine surgery. We welcome any questions. Thanks for listening.
Thank you, Dr. Wu. Now we will now open the question in the floor. Okay, my own question is about the complication of the thoracic open laminotomy versus thoracic endoscopic laminotomy with bilateral decompression. Your result is that the complication of open laminotomy is higher than unilateral endoscopic laminotomy with the bilateral decompression. In my experience, during the endoscope surgery, dural tear was happen. That is so difficult to manage the CSF leaking. Do you have your own good management tip, Dr. Wu?
So you all can hear me, right? So in our complication series, we have basically one incomplete decompression in each group, and one hematoma in each group, and one incidental durotomy in each group. Oh, sorry, there's no hematoma in the endoscopic group, and hence there are 2 cases out of 31 in endoscopic group and 3 cases out of 20 in the open group. So there's a durotomy in each of the series as well. In our endoscopic technique, the incision is rather small, and then when there's a durotomy, we tend to use the patch blocking dural repair with Tacocil. In open surgery, when we do have a dural tear, they tend to be pretty big as well, as you have mentioned. And the usual technique is either we're using a patch repair with Tacocil, or using a durogen, and then we stitch the durogen next to the edge. It's not easy to stitch, of course, under neurosurgical hands with experts, we can do that. However, it's also not easy to stitch at the cord level. So a lot of time we also use the patch repair. The good thing about endoscopy is that it's a small incision. It's easier to manage the wound when you have a patch blocking repair. And as a result, there is potentially an advantage when you have an incidental durotomy during endoscopy. However, this technique, I have one thing we have to mention. We do this when we have done a number of lumbar endoscopic decompression, and also manage a number of lumbar endoscopic incidental durotomy. Then maybe you can proceed on to do this in the thoracic and cervical levels.
Thank you. And we will move to next speaker. Next speaker, let me